Good morning, everyone. My name is Lori Hartwell, and thank you for attending this important webinar. Today, we have a very special guest. I've known Dr. Jordan since I was a little girl. That was, many years ago. I haven't grown that much, but he is definitely a pioneer in the community, and he is responsible for making my transplant possible today. He is going to speak today on the latest technology and innovations for post-transplant care, and he is the Cedars-Sinai Director of Nephrology and Immunology and Transplant, and I have to say we need to add genius to the end of that title because he is so incredibly knowledgeable and responsible for a lot of our health and well-being. So Dr. Jordan, thank you so much, and I'm going to turn it over to you.
Well, thank you very much, Lori, and for your kind words, and I really appreciate your thoughts this morning. What I want to try to do today is to talk to you about what I see as emerging therapies for our transplant patients in the next few years. And I think hopefully you'll see there's a lot of good things going on. So I'm going to share my screen and let's see if this comes out okay. And then I'll see if you can see it. Can people see the screen?
Yes, we can.
Would it be better to do this or not?
If you can just show one slide, it would be better. Like
okay.
Just start the slideshow.
How about that?
I mean, that works, but you can see your next slide, but that's fine.
Okay, I can try to do the, I think there's a problem showing the...
Go up to slideshow and put play from start.
Okay, and this is slideshow, and this is, okay. So, but can you see that one? Can you see that slide?
Somebody just says F5 starts slideshow, F5.
Okay. I've got some problem with the computer here for some reason, as it says sharing is paused for some reason. Let's see if it, okay, hold on a second, resume share. Does that work?
We can just see your one slide.
Okay,
and everybody can see it though. I think you can continue. I think.
Okay, okay, let me just see, I'll say resume share. So this is the title of the talk. And let's see if I can get to the next slide. Oh boy, let's see. I think I better, I think I'll go the other way because this is not working. Okay, there it is. So let me know if you can see these things or if there's a problem. I can go back to the other screen. But what I want to talk about today are what are the major challenges facing transplant therapeutics. And from my standpoint, there's several, and we can obviously there's more than we can talk about in the time allotted, but I think toxicity and pill burden of immunosuppression is a big issue. Antibody-mediated injury to allografts, we'll talk a little bit about that, where people develop antibodies that slowly hurt the kidney and cause them to fail. Desensitization, people who have had previous allografts make antibodies, as Lori had indicated, and trying to get them a bridge to a new transplant. And then designing future therapeutics. Where are we with that? So first I want to talk about antibody-mediated rejection. And CABMR is chronic antibody-mediated rejection. And this is a real big problem because for many years, when we looked at, I think the major issue is that when we've looked at short-term outcomes with current immunosuppressive protocols, they're pretty good, 95% one-year graft survival. But if you look at the long-term outcomes over the years, it hasn't changed at all. And for some reason, the kidney sort of grind down to a halt and will slowly lose function. And none of the immune suppressants that we have early on have made a difference for that. People thought, well, maybe this is because of cyclosporin or prograft toxicity or recurrence of diseases like diabetes or high blood pressure. but it's really become a more elucidated recently what this is really about. And what it is antibody. It's a little cartoon that I drew, and I'll try to show you what, I know it's early in the morning on a Saturday, and hope everybody's had their coffee, but over on the left side, we have what we call antigen presenting cells, or APCs. And the kidney, when it's transplanted, it recognizes a foreign target like HLA. And under the guise of and direction of what we call cytokines, the interleukin 6 and 21, it drives naive T cells to become what we call T follicular cells. And these T cells activate B cells, or antibody produced, or that it will be antibody producing cells, to move through this process from left to right to make antibody, the red antibody.
Dr. Jordan?
Yes?
You're still, we only see your first slide still. So I know
I'm
you're
sorry.
showing stuff. So you may want to.
Let's go back to this. I'm sorry. Let's go back.
That works, actually.
Okay, let me just, there's some problems with this. I'm not sure. So here are our major challenges. We talked about toxicity of pill burden, antibody-mediated rejection, desensitization, and designing for future therapeutics. And antibody rejection, as I mentioned, is a major cause for graft failure. And one of the things that we have seen is that this really is what's causing the short half-life for grafts. And we'll talk a bit about why. Now, this is the slide I wanted to talk about. It is a cartoon. It looks like where we see how antigen-presenting cells activate what we call naive T cells and they become T follicular cells. These are important cells because they activate B cells and lymph nodes to make antibody. And the red antibodies are what we call complement activating, or really nasty antibodies. And we can detect these in our test. And we know if you have these, they cause rejection and can cause graft loss, not only for kidneys, but also for heart transplants and lung transplants. The next slide is a paper that in our professional groups has really helped us a lot. This is from Dr. Lupi. He's one of our colleagues from Paris. And when we look at antibodies, we had this big advance a few years ago of detecting donor-specific antibodies. And these are HLA antibodies that you saw in the previous slide that injure the graft. And what Dr. Lupi found was that when he looked at a large number of patients, over 1,000 patients in Paris, and went back and looked at biopsies and had this new test looking at donor antibodies, he found a couple of things. On the right side, you can see that if you have no antibodies, the black line at the top, you do really well. This is a really, really important issue because, and the reason most people don't develop antibodies, either they have very well matched kidneys and most importantly, is that they take their medicine regularly, because what we found is that people who do not take their medications regularly, tacrolimus primarily, develop these donor-specific antibodies. And you can see what it does. Number one, the red line shows these complement activating, or those really bad antibodies. And you should see at 7 years, the graft survival is about 40% if you have those. However, some of these antibodies are not doing too much. These are, we're not, so it's, it's not a perfect test. You can't say if you have them, you're going to do really poorly, because in the blue line, you can see that they're almost as good as those who don't develop if they don't activate complements. So, and on the left side is just pathology. I won't go into that, but needless to say, the red bar here, the patients that had those really bad donor antibodies had much more severe pathology on kidney biopsies. So antibodies can be different. The other thing we know is that if you look at, and I'll just focus on this graph here, a graft survival curve, that if you have antibodies when you're transplanted, this may not seem, or it may be counterintuitive, but it's not, is that if you have antibody rejection and you have antibodies when you're transplanted, you usually do better than if you develop them over time after transplant. And I think the reason for this is that this is more of a clandestine or masqueraded type of injury where people may be intermittently taking their medicines. They can develop these types of antibodies without really much change in their serum creatinine for a long time, and then all of a sudden you've got a problem that's irreversible. And we did this, we saw the same thing at Cedars. This is Dr. Haas and our group looked at this. And what we found, the pathology is different. And I won't go into that except to say that this feature on the right side, antibody rejection, ABMR it should be, is with donor de novo DSA, or where people make new antibodies after transplant. You get this thickening of the filtering unit of the glomerulus, and this ultimately has a very poor prognosis. As you can see below, that these kidneys fail much more rapidly than if somebody has the type 1.
Dr. Jordan, before you move forward, I just wanted to emphasize that what I've learned so much from you is that the antibodies are better to detect than the creatinine, because we're talking about chronic rejection, which gets all of us eventually if we don't watch out. Not all of us, majority of us. And so this is just the step before detecting antibodies before the creatinine. I just wanted to make sure the audience understood that, because
Yes.
I find this so fascinating, because I have one of those antibodies at transplant that is still there, and seeing that previous graph that it's better to have the antibody when you're transplanted as opposed to being created in the future is exciting to me. So I just want to stop there and just, I think that's really amazing that we're able to prevent that. So I'll stop and let you continue.
Yeah, I think, you know, the more we learn every day, all this knowledge and experience is very helpful in understanding what the major problems are and how we have to get after it. And this basically, we showed the same thing that the French guys did. Now, the thing that I want to go to next in this slide is when we looked at factors that were associated with graft loss, on the bottom here, this is the most important thing for me, is that when we have treatments, current treatments, and treatments to lower the antibody that we have and had at that time in these 80 patients, if we could not lower the antibody, that's the lower graph, if we could not move it with our treatments, graft loss was inevitable. If we could change it, you can see they do much better. So failure of therapy to reduce these antibodies is associated with poor prognosis. So we have our work in front of us. We need to develop therapies that can get rid of these antibodies, and that way we can expect better outcomes. Now, this just shows you the same thing. This shows you the magnitude of the problem in today's world. And this is, on the left side is the graft loss percentage based on whatever, all the things they found on biopsy. You see that 40%, the majority primarily of all of causes for graft loss in France were from antibody rejection. In the US, about 50%. And what we know is that in the US, we lose about 5,000 grafts each year, all from all vintages, primarily because of chronic antibody rejection. So developing therapies, and this is, I think, a very important point to address this issue, and this treatment of this condition, I think, is really critical to improving long-term outcomes in our patient population. If we can make kidneys last longer and give them a much longer, patients a much longer time with good kidney function, is going to be very important to prevent them coming back to the transplant list, also having to go back on dialysis. And this, I know this is an article we just wrote recently looking at emerging treatments. If anybody's interested in this, this is in the American Journal of Transplantation. And we go over, and the thing I just want to point out down on the bottom are the number of new agents that are emerging to treat. And we'll talk about some of those this morning as well that are coming into play here to help our patients. Okay, so let's go on to the next thing. So, and this ties hand in hand with antibody rejection is what is the rationale for future drug development and desensitization? So desensitization is a therapy where, as Lori mentioned, Lori had previous transplants as a child and had, with our existing drugs at that time, did the very best she could. But when grafts are lost, often we have a very large retinue of antibody that are directed at multiple targets on future transplants. And so we have to be able to try to get rid of them and to knock them down to allow for a successful transplantation. And again, I won't spend too much time on this, but what we have found now, and the knowledge we have from immunology, is really meshed well with development of therapeutics, and how we know the B cells are the source of the antibodies, and that the antibody targets on, there's what we call antigens, or and the antigenic anatomy of these cells can be used to develop therapeutics. And I'll talk about some of those today. And some of the therapies are just addressing the antibody way over here. Some cytokines, you saw that IL-6 and thing that we showed earlier, that this is like a jet fuel for these cells. And if we can block that, we can slow them down. And then targets to destroy them, like CD38 and BCMA. First one I want to talk about is and I don't think some of it shows up here, but the antibodies, if we look at how cells are, if you look at HLA targets on immune cells, and forgive my little cartoon here, but the little squiggly lines are targets, HLA, on the, say, endothelium of a kidney transplant. Now, if we put this into a person, and their antibodies there, you can see the antibodies are the upside down Y-shaped things. The antibodies bind and they activate injury, and the two pathways that are very important are what we call CDC, or complement dependent injury, and then antibody dependent injury. So complement is activated and kills cells, and these cells, called NK cells, or natural killer cells, will recognize antibody bound to a tissue, and they say, something's wrong here. There's an antibody binding, so let's go hook up to it and release a bunch of toxins to kill the cell. That's good when it's a bacteria. It's really not so good when it's your kidney. So one of the first advances I want to talk about is a drug called Amlifidace that we've been working with since 2014. This drug was called IDAS initially, and this is a drug that was developed, it's actually an enzyme that was developed from a bacteria called Streptogenes. And this bacteria is notorious for causing flesh-eating bacteria, flesh-eating fasciitis. And you've heard of that, I'm sure, on the news, where people die from this. And from that infection worldwide, about 300,000 people die every year. And so the strep is really a bad bacteria, but it has what we call virulence factors. And this is very fascinating to me. And one of the virulence factors for this particular streptococci is called IDAS, or Immunoglobulin Degrading Enzyme of Streptogenes. So, the antibodies kill those bacteria, so they say, we got to do something about it. And what they did is make this enzyme that will chop the antibodies in half, so they can no longer injure the bacterium. Well, this has been adopted by the enzyme developed by this Swedish company called Hansa Biopharma. And what it does, as you can see up on the top, it cleaves this FC fragment off of IgG and basically prevents any complement or ADCC injury. So the idea is, when I talked to these guys, they said, we think this would be good for desensitization. Patients that have antibody, we could treat them and potentially prevent injury. And so we did a study, and fortunately was published in the New England Journal a few years ago. And that's exactly what we found. And I know you're probably not used to looking at these bar graphs over here on the right side, but this is very dramatic information, because the red lines show these very strong antibodies that would, if you needed a transplant, you could never get by it, even way out. So basically it's a 100% sensitized patient with high MFIs destined to stay on dialysis really for life. And this is one of the first people that was treated with this drug. And you can see that the blue bars, within 6 hours of treatment, all of it is basically gone. So we're removing this. The bottom line is even more important, because what you see here is that you can't even see any antibody down there. This is 1 hour. This is the complement activating antibodies that in that Dr. Lupi paper I showed you above, were the worst kind of antibodies. So we can get rid of them very quickly. And this allowed us to go forward and transplant patients. So I won't go over all this with you, but basically we found that this drug really worked. And when we gave it to people about 6 hours before their cadaver transplant that had antibodies, it would get rid of the antibodies, and it would allow these patients to be transplanted. And this next slide shows you, and I'll focus you up here, that one of the things we also learned, and I won't bore you too much with this, but basically we had two groups, a group in Sweden and a group in Los Angeles that were treated. The Swedish group, you can see the bar here was, this is beforehand, the antibodies, 6 hours, it's all gone, but within 1 month, they're back. Now we gave our patients IVIG and rituximab, which also helps block the antibody from coming back. You can see here's that at beforehand, 6 hours and 1 month. So we got a really good durability of this in knocking down antibody and injury. So we feel this drug, and I wanted to mention, I'm very proud of this because this work that we did together has now allowed the drug to be approved for desensitization in Europe. And we're waiting for this to go through the FDA. So it will, in fact, will be, or is the first drug approved for more than 12 or 13 years in transplantation. And this will be for desensitization specifically. So we're excited about this. The next, what I want to show you is in terms of desensitization and antibody is this. This is a gentleman, he allowed me to use his photo, but I'll show you this. This is a drug called clazakizumab. It's an interleukin-6. That's the jet fuel that drives the immune response to alloantigens. And this is a guy who's getting it for antibody rejection. He's already got antibody rejection. We wanted to slow it down. But we do it for desensitization as well. And I want to show you this because I think it speaks to future therapeutics. That's one of the things that So this is the first patient to get this drug for a kidney transplant indication. You can tell it can't be too hard because I'm giving the shot. So not a nurse. So this is like an insulin shot. It's 1 cc given every month. So the power of the biotherapeutics, I think, is really relevant here. And this gentleman has been doing very well for more than almost 3 years now and has retained his kidney where it would usually be lost. We've also used this drug for desensitization, and it's probably one of the best that we've seen so far, where we can see that treatment of patients over time, we can lower their antibodies down just with this monthly sub-Q shot. And again, I don't want to bore you too much, but after transplant, what we have done is kept this going. So here are the antibody. You can see they're very big like they were before, and like with the itis, but at transplant, they're very low. And you can see over several months, up to a year, that they go away. So this is very unusual. And when we biopsy these patients, we've seen that they had really good features on their biopsy, not much inflammation at all. We've now entered 20 patients into this study as a clinical trial. We have transplanted 16 of them, and we have had no graft losses. So we're very happy about this, and we think this will be a nice way forward, in terms of not using very large treatments like pheresis and high-dose IVIG and things like that, which may always be part of this, but this could really be revolutionize the desensitization. So once we have transplanted patients, how do we monitor them, especially if they're sensitized or not? Many places do protocol biopsies where they're biopsying people 3 or 4 times a year. This is quite a burden, I think, for patients, and certainly some biopsies are needed and are indicated, but we have thought that protocol biopsies are not really that necessary in monitoring. But we do need something else. There's no question that things can happen and inflammation can occur where the creatinine is not really that helpful. as Lori indicated. So one of the things that we've been doing in terms of looking at monitoring, and we participated in this study called the DART study, and this was really quite a revolutionary study in my mind, published in 2017, where we looked at what we call donor-derived cell-free DNA. And the test we used is called the Alisher test. And what we looked at, and again, not to be overburdensome with the graphs, but in this graph at the top, we looked at the ability of this test to detect rejection, and it's very significantly can detect rejection in patients. You can see that the percentage of donor-derived cell-free DNA, if it's higher, is and certainly above 1%, is strongly indicative of the likelihood of a rejection process. Down here, these people do not have it. And in the past, what we used was serum creatinine. You can look at here, you could flip a coin and do better than that. It has no ability to detect rejection. And one of the things that we did working with CareDx was to look at combining donor antibody testing. As you saw earlier, that's very useful, but some of the antibodies, as you know, may not cause trouble. So we can combine the donor-derived cell-free DNA and donor-specific antibody. We can, I think, potentially do a better, develop a better assessment of things. And this is what we found in that study. This was also in 2018, that if you looked at these cutoffs for donor-derived cell-free DNA in the test, 1% is usually for rejection. It's very sensitive and specific for, and has very strong positive predictive value and negative predictive value. That is, if it's negative, it's no rejection. If it's positive, there is. And this is about as good as it gets, I think. So if there's antibody and positive Alisher tests, we know we have to do a biopsy. We know we've got a problem. Now we have seen this, the counter to this, and this is really helpful because we had one patient that had a positive donor antibody, which most times would be biopsied, and when we did our Alisher, it was negative, and so we decided just to watch. And she's from Seattle, and when she went back up there, somebody biopsied her anyway, and they showed no rejection. So that confirmed what we had seen with Alisher. A few more things about this. One of the things that we think in the future is going to be helpful, and this is a study done by Dr. Ed Wong and as one of my colleagues at Cedars, looking at if this donor-derived cell-free DNA combined with biopsy can predict loss of kidney filtration rate over time. And we certainly think, and what he's shown is that that is true. And I won't, it's a table with a lot of statistical stuff, but it is an important finding, and that we can show that combining cell-free DNA tests, if they remain positive over time, really will predict poor outcome, especially if the features on biopsy are already progressing. So there's a lot of ways to look at this. Now, what I wanted to show you now is a few cases from our experience at Cedars, and just to sort of reinforce how important this information was for us when we first started using it. And the first patient is a 64-year-old HLA-sensitized Armenian female. She had renal failure secondary to diabetes, and she had a deceased donor kidney transplant in 2014. Donor was incompatible. Her creatinine was very good, 0.7 to 0.9 for the last 3.5 years. And she presented in August 2017, creatinine was normal, no proteinuria, but we checked her DSA and hey, it was slightly positive. The patient was on Coumadin because she had AFib, so you know she's a real high likelihood of a bleed. So I asked my colleagues, I said, what would you do? Would you biopsy her? Would you repeat the DSA, ignore? I think any of these would be good suggestions except ignoring, because the antibody is there. You might want to wait and see what happens. But at that time, we were just getting the Alisher test up. And so what we found was that her Alisher was 3%, very high. And we biopsied her, she had antibody rejection. Now this lady would have waited probably a year longer with a lot of progression of kidney dysfunction and antibody injury and going back to dialysis had we not done this. And what we saw allowed us to treat her earlier and to set her back on a good path, and we got rid of the antibody. So this is an important, I think, this showed us we really can't rely on our clinical comfort zone with serum creatinine at all. The next patient is a patient that had, is a 64-year-old as well. She had a previous transplant. She kept it for 21 years. She was really good, but she had chronic antibody rejection, and we did not take out the transplant. She did have this, what we call AT1 antibody, AT1R, which is another antibody that can injure the kidney. So we did desensitize her, and she got also ABO incompatible kidney transplant from her friend. Her creatinine was really good, 1 to 1.3 for the first year. She had a lot of tacrolimus toxicity. So at 1 year, I thought about biopsying her because we wanted to convert her over to belatacept. And what we found with her is that she had, you can see her serum creatinine was really good there, and she had a DSA or Alisher of 4.8%, very strong. So we biopsied her, and you can see that she also had antibody rejection. So we treated her. So again, you think things are great, looking at that serum creatinine, you can't do that. You have to be able to monitor with a test like this. The last case I wanted to talk about is this, a lady, let me skip here. It's just a 22-year-old lady who had focal sclerosis. She was 8 years post-transplant. And in 2017, she had a creatinine of 0.9. She'd been stable at 0.7, no proteinuria, good tacrolimus level. And we did just routinely measure her DSA. And she had, again, a low level DQ5 and the same sort of issues. Would you do anything? Would you monitor her? And at that time, we did not have the Alisher, or Alisher was just coming with this, but we did biopsy her first. And she did have antibody rejection, the glomerulitis and chronic features. Now her Alisher showed 1.4% at first. And then we treated her because it was sort of a low grade with anti-IL-6 therapy, which we know can slow down this whole process. And you can see that it went down to 0.89. Now her insurance decided not to pay for any more. And you can see that in a few months, it came back up. So what this told us is that, wow, this is really an important thing, because this shows us that we can monitor patients for a loss of allograft and in terms of, or excuse me, for loss of control of the antibody rejection process. And when we stop therapies, it comes back. So this is a sort of turn things on our ear a little bit, because we think we treat them at rejection, it's gone. It's not. So we have to we can use this, I think, to monitor patients over time to see if we have efficacious therapy for rejection. Now I want to close with the next few slides to talk about and I don't have all the slides in here because we had some, I don't want to go on with this, but basically what we have seen with this anti-IL-6, tocilizumab and claza, is that it is very effective in treating chronic antibody rejection. It slows it down, it stabilizes the GFR, but we were interested in why. And I wanted to show you some data going back to our study with from that initial slide I showed you, where the targets for modifying the B cells and plasma cells were. So this drug is a drug, clazakizumab, for IL-6, the jet fuel that drives the plasma cells. And you can see that, and when we treat these patients, that 6 to 12 months after transplant, these are desensitization patients, that these cells are really going away, that we're knocking them down. And that is associated with that antibody reduction that we saw earlier. And what's so interesting to me, and I'll just talk about this because as a future, I think, is that when we looked at these types of cells in the patient's blood at, before transplant, at transplant, and then 6 to 12 months after. And there's a type of cell called regulatory T cells, Tregs, and Bregs. these cells are known to turn off inflammation and to suppress rejection processes and also autoimmunity. So these patients are developing, with this drug, very strong responses in the Tregs and Bregs. And so we're very interested in this. I just want to show you a little bit about this because the emerging ideas about this are very interesting and tie right in. Now the B cells, which make these anti-IL-6, as I showed you earlier, if they're inflammatory, they stimulate T cell rejection. They also stimulate antibody production and then macrophage activation. However, if they don't have that, they tend to turn this off and they tend to upregulate Tregs, and because of the IL-10 and 35. And what we think is happening here with this therapy, and we think it's a spinoff that we really didn't expect, is that with our anti-IL-6 therapy, we deviate the B cells to induce Tregs and to block this inflammation, which results in low levels of rejection post-transplant. Now, is this of any clinical relevance? Well, yes, it is. There are protocols around the country now that are being developed, and we are doing it at Cedars as well. We've just hired a gentleman from Dana-Farber Cancer Institute in Boston, who is an expert in growing Tregs and developing regulatory T cells from patients. So if you can see here, you have a donor or you have a donor and recipient. We can take cells from the potential recipient and isolate and grow regulatory T cells in vats, and then use them at the time of transplantation or after transplantation to suppress inflammation. Now, these kinds of studies are ongoing, and we're developing these protocols at Cedars now, and we think what's going to be a very important part of this, as our colleagues at Mass General do too, is using anti-interleukin-6 in this process, where we can sustain these regulatory T cells and B cells to prevent rejection, so that the things that right now, I just wanted to mention that we do have already patients, we have maybe 5 or 10 who are being treated with no tacrolimus and no CellCept. They're on belatacept, which we didn't talk about, but belatacept is Nulogix, which we use to replace tacrolimus, but they have to have CellCept. But we use that plus the interleukin-6 monthly. So people are on one IV shot and one sub-Q shot monthly for their immunosuppression. And we're following that very carefully. But we think that using this to enhance the Treg development from peripheral blood and give that back to the patient will really help and suppress B cell responses and give patients less of a medication burden. In fact, that may be the only thing that they need. But that is what's coming. Now, so if we look at this in final, we can see that the anti-IL-6 is really interesting because it can knock down the antibodies, it knocks the plasma cells down. It also interferes with T cell share and would tend to increase Bregs and Tregs that would just sort of turn off the inflammation and prevent rejection. And so I think that just a couple of comments here, and then at the end, is that there are now many protocols that will improve the lives of patients that receive organ transplants in the coming years. We're new desensitization protocols. We have new therapies for antibody rejection. And we have new protocols that will minimize exposure to toxic drugs. The Alisher test is a very important part of this because we think we can monitor efficacy of our immune modulation and treatment of rejections. And I think I pointed out to you today just a few of the things, but certainly the IL-6 story is very important. I think the Treg story is going to be very important, and the drugs like Amlifidace are going to be very, very helpful in getting people to transplant. And we're also doing Amlifidace studies to treat antibody rejection, where people would not have to get plasmapheresis. And we hope that will be useful as well. So I'll conclude there, and I'm happy to take any questions, I guess, Lori, whatever you think.
Yes. Well, thank you, Dr. Jordan. I have a couple of questions. Can you tell a little bit about how the difference between antibody testing and do nephrologists prescribe that? Because, and the difference between a nephrologist and a transplant nephrologist.
Mhm.
And then also, how does the creatinine relate to the DNA testing?
Yeah, very good question. I think that, we do want, I think that's something that I think the people at CareDx would really like to see, would be more understanding of these in the general nephrology area. And some of our guys are on it. Not everybody is. And I think as time goes by, we would really hope that we could implement it in the offices where people are seeing. As I mentioned, I think looking at serum creatinine is archaic. It's not, except in extreme degrees for somebody's already way down the road with an inflammatory process. So it's much better to get after these things where we can see, the donor-derived DNA and the plasma, and certainly do antibody testing as well. It is a little bit difficult for this to be done from a nephrologist office, but I hope this is something that can be done in the near future. Certainly, we'd always welcome referrals, to our clinic if there's any questions about what are going on. But I think we can't just depend on the serum creatinine anymore.
Well, and it's fascinating with the creatinine, because what I've learned from hearing different people speak is once the creatinine starts moving, it's the beginning of chronic rejection. So you want to go upstream and prevent the antibodies from even detecting the kidney, like a video game. I love how you explain that. And I have one antibody that is a B8 antibody for almost 10 years now, and it's been managed with your guidance that it has not created any havoc, and I have a 0.7 creatinine, so it's very exciting. I wanted to, there's a question, are Alisher tests being done on all transplant patients, or are they checking for DNA, and can Quest Labs do the test?
Yeah, that's a good question. I'm not sure. I think, the one thing that we have, this is all evolving. The CareDx people have been exceedingly helpful in this regard, in terms of they can send, they have a group of nurses that will go out to patients' home and draw and send the test to the CareDx in San Francisco for analysis. So they're being very proactive in this regard. And in terms of, is it available or done everywhere? Not yet. I think people are coming around to this. People's comfort zone about creatinine and biopsies is something that's sort of hard to, to sort of get at, in terms of where we, how do you get this, information out there to them? And we're trying very hard, because in my opinion, I think it's been a really major advance in our ability to take care of people without having to do a lot of biopsies.
The next question is, should the test be done for patients with 12 years post-transplant?
Yes, absolutely. I can't tell you how many people we pulled up. We see them yearly. Everything, looks great, looks great, looks great. And I said, well, let's just do an Alisher and a DSA. And, all of a sudden you go, oh, it's 2. Oh, it's 3. Let's do a biopsy, and they'll have chronic antibody rejection, even though their creatinines are fairly stable. Now, if we can treat at that point, maybe we can make that kidney last 3, 4, or 5 more years, rather than waiting until the creatinine's 2 or 3, where we have no opportunity to change the course of the kidney.
With that, one of the other questions: did you read the book Life of Henrietta Lacks?
I know about the book. I know all about the HeLa cells. I have not read that book, no, but I know very much about that, and I think that's a really good story. But in terms of like, in terms of like this Treg stuff, now this will be a little bit different, but there will be similar issues. But the Treg cells that we would be taking right now would be for that patient.
Okay, well, it's great. I
Not
think
for other
you should
patients.
read that book, because it really gives the kind of the precursor to all of what's going on, which is really exciting.
Yeah, no, it's very important. Cell therapy is really the future, I think, of cell and antibody therapy for our transplant patients.
Well, and also too, a lot of people are just following up with their nephrologist. and they're not seeing a transplant nephrologist. I can't specify how different these doctors are because one's trained in chronic kidney disease and dialysis, the other one's trained in transplant. So can you get your nephrologist to do these tests, or do you need to go to a transplant center?
I think right now transplant center is important. I mean, what we like to do, and I'm sure our colleagues at UCLA and other centers would really, we like to see everybody at least yearly that's out there. And because, as I mentioned, I think there are things we can do to, pick up problems. Donor antibody testing, the Alisher now, there's simple blood tests. And if we can change the direction of your kidney in terms of, instead of going down, that we can stabilize it, make it last longer, it's something really that right now, and probably for a long time, will be in the transplant center. So I think we at least should see the patients, the long-term patients, every year.
Yeah, I every 6 months, I believe people should follow up at the transplant center and then with your nephrologist. Is this available on the East Coast?
Yes, it is.
Okay.
Centers, a lot of the guys at Hopkins and Northeast and Washington D.C. area are doing Alisher. Not every center does, so, but there are centers that are doing Alisher there. Yes.
Okay. Somebody else asked, my DSA tests have been negative for the past 2 years since my transplant. Can it turn to positive, and why?
Yes. There are a couple of issues there, Lori. I think it's very, very important. These are great questions, by the way. It's something we grapple with every day. Donor-specific antibodies, when we usually talk about that, are HLA. And I did not put in today's talk the concerns of non-HLA antibodies, because we do see more and more people who have some graft dysfunction who've always been DSA negative. And we biopsy them and it looks like antibody rejection. So what we know now is that they're what we call non-HLA DSAs. So if somebody's creatinine is not doing well and you've got some proteinuria, Alisher test is also very, very, very helpful there in terms of, okay, it's positive, but you don't have DSA. What do you do with that? And what we found that there are often these non-HLA DSA positive rejection. So it's the same injury to the kidney, but it's a different antibody. So DSA in and of itself is not sufficient to screen. And I think that's where the Alisher is really helpful.
Okay, I'm going to try to bring a couple questions together. People are saying, how often should you get Alisher? And is it, how long does it take to get a result? And do you need more than one?
Yeah. Well, there are different recommendations. Basically, some people, there are studies going on looking at sequential monitoring. Also, what we've done is mostly look at look at for cause, where we are suspicious. Maybe we have a low-level DSA, or we're just, certainly for protocols, we're seeing people every 6 months or every year, we really want to do that as part of our routine. That may vary from center to center, but we find that we're really capturing a lot of information that way. The most important thing, though, that we have seen with this test is that it has drastically reduced the number of biopsies that we do. Because if we get the negative predictive value is so strong, if it's low, we know there's no immunologic injury with a high degree of certainty in that kidney. So we don't have to do a biopsy. And so I think this is another great value for the test. But I think in terms of how often you're needing it, we do for cause, and we have a comfort zone knowing where we need to assess it and where we are, where things are okay.
Okay, and then one other question I have is, I can see that the IL-6 protocol would make a huge difference for people who have IgA nephropathy and autoimmune disease. Is there any other research that would help, or one of our attendees?
Yeah, that's a great question. In fact, for IgA nephropathy, there's data now from animal models that IL-6 is very important in driving that. So, and we're seeing a lot of the drugs that we use in our transplant world are exceedingly useful in our nephritis patients. I have pretty big nephritis clinic at Cedars, and we're using these drugs and with great efficacy and low toxicity compared to what has been recommended. Where many of the old protocols now that have been recommended for treating glomerulonephritis, high-dose steroid Cytoxan, are very, very toxic. And so we find that these antibodies, these monoclonal antibodies, are exceedingly useful. And I think IL-6 is going to find a role there too. It's used in a number of autoimmune diseases at this time. And what we found, I did not show the data, but we have a 7-year follow-up on the tocilizumab for the chronic antibody rejection. And we saw dramatic differences, not only in graft survival, but also patient survival. Patients who have kidneys that fail, that go back to dialysis, tend to not do as well. So we think this is a very important finding, and we hope that these drugs will be available. They are available. The tocilizumab it's a infusion, but I think like the CLAZA is now being studied in the IMAGINE study, a worldwide study for labeling for treatment of this condition. So having sub-Q once a month or every other month would be a great therapy to have.
And the last question, we're everybody, we're running a little bit over. Please stay with us because this is really great information. What is the margin of error, or do you just repeat the test if you feel that it may be off?
The Alisher test?
Yeah, is there like a margin of error?
Yeah, there's margin of error. I think, the statistics on this are very good, and anybody who wants to read the paper, I think that the papers have been published. But basically, for antibody rejection, we now know the cutoff is about 1%. But if you're looking at cell-mediated rejection, recent data suggests that 0.5%, above 0.5%, Alisher positivity is associated with significant inflammation, and below that it's not. So we're really now getting to a point we can say, hey, we know exactly what's going on here and when we need to biopsy a patient based on the information from Alisher.
Well, thank you, Dr. Jordan. This was very informative, and we did a podcast together that talks about desensitization that we'll put in the link to people who participate so they can hear the whole, how antibodies and blood transfusions and, how all of this therapy is helping us have transplants. I'm living proofs of a 4th transplant with 100% antibodies. So we really appreciate your time and your expertise and again, commitment, because you've been doing this for a long time and you've been burning the midnight oil. And, I appreciate scientists and people who study, and, I've seen your remarkable progression over the last several decades, and you've really changed the lives of many people. So I thank you on behalf of patients.
Thank you. And I think that just one comment, I think that I always feel that bringing scientific investigation to medicine is the best way to go forward and develop therapies that are rational for us, and hopefully will eliminate some of these issues that plague us right now. And I really do appreciate your support and your commitment to this area.
Yeah, you're amazing.
Well,
Well,
thank you very much.
And if you would like to stay around, there may be some more questions, but I'm sure you got a lot to do. So thank you so much, and I'll see you at clinic.
See you at clinic. Bye-bye. Thanks, everybody.
Thanks
for your attention. Bye-bye.
Bye. Thank you. Well, everybody, we're going to introduce our next speaker, and I just want to let everybody know that everybody who attended the webinar, we're going to send them a pretty mask in the mail. We're going to also send you one, Dr. Jordan, so
Thank you.
you could give it to your wife, or you can wear it yourself. It's pretty. We have a male version too. So our next speaker is Corinne. Corinne is the product manager at CareDx. She has almost 30 years of health management experience, of which 20 years has been spent managing financial, operational, and quality improvement initiatives at nephrology practices, dialysis units, and transplant centers. Her passion is improving patient care through patient education engagement. She has spent the last 3 years developing software solutions and clinicians and patients in these areas, including the development of the Allocare patient app. So we're going to learn a little bit about that, and thanks for joining us, Corinne.
Thank you, Lori. Thank you, Dr. Jordan. That's a tough act to follow. Hopefully I can meet those expected, now we've set the bar high, hopefully I can keep up. And thank you all for joining us today. Thanks for taking a little bit of time on a Saturday. So yes, to talk to you about Allocare. What is Allocare? Allocare is our new patient engagement app. And why Allocare? Why an app to help with this? Well, what we know is that one of the ways that transplant patients can help to extend the life of their kidney or their organ, or to have those best outcomes, is to really remain compliant with all of the many things that you have to do to take care of yourself. And we know that patients who understand and know what they have to do a better job of keeping up with that schedule, right? That's not too surprising information. So why is it so difficult? Why do people struggle a little bit? Well, there's a lot to learn in transplant, right? For all folks who have an organ, you know how much you had to learn in a very little amount of time. You were probably in the hospital only for a couple days after your transplant, and you had to retain a lot of new information. It was a different schedule. If you were on dialysis before, you now had to drink more and eat different things and pay attention to different things. It's like a whole new language. So you had new words to learn, like CMV and immunosuppression and rejection. Just the talk that Dr. Jordan gave this morning, that's not information that the typical person on the street knows or understands. And so there's a lot to understand. There's a lot to know. There's a complicated medication schedule, long list of medications to keep up with, lots of things to do and pay attention to during the day. And maybe sometimes you just need a little help in doing it, but with COVID, family and friends can't be around as much as they want to be or as much as you want them to be. And if you're out looking for information and weren't lucky enough to join us for a webinar like this morning, you never know what you're going to find when you Google search anything, right? And how can you trust that information? And so the Allocare app was designed to try to put all of the pieces together and give you one place to manage all of that new information, that new schedule, that new lifestyle that you have, and to help you really adhere to it well to extend the life of that organ. So first is medication, and this is probably the most important part of the app. So the app allows you to pull your medication list directly from your medical record. It helps you then set up your schedule and keep track of that complicated medication schedule, that long list of medications that you're probably on. It helps you to manage the day-to-day schedule, as well as those things that you only take once a week or once a month. You set the reminder, you set the schedule, and then the app kind of does the worrying for you. So it's going to tell you, remind you throughout the day when it's time to take the medicine. It's going to tell you exactly what to take, exactly how much to take of it. You can even upload pictures of the medications to kind of help keep them all straight. That's helpful when you're adding new medicines or changing medicines, or when the pharmacy has given you a different generic yet again, help you kind of keep track of those. There's lots of other things that you're keeping track of to help keep you healthy. Things like your fluid intake and if you're right out from transplant, your urine output, weight and blood pressure, things like that. This allows you to put that all in one place. When we were developing the app, we were talking to patients about what would be helpful to you. And they all said, you know, I have this app that tracks this and this app that tracks that. And I've got 5 or 6 of those that I'm trying to balance. Well, we put it all in one place. And so now you can actually start and stop those metrics as you go through your transplant journey. So this part can be as customized as your medication list to you and what you need at that time. No longer tracking your urine, turn it off. Need to start tracking your blood pressure, turn it on. You can then set daily goals and customize reminders. So the app will help stay on track with those goals as well. And it is Bluetooth enabled. So if you have a Bluetooth enabled water bottle or a Bluetooth scale or a Bluetooth blood pressure cuff, this will talk to that and kind of limit the amount that you actually have to manually enter. You're going to want to be able to see your progress over time, right? So in taking your medications, as well as how much you're drinking and what your blood pressure looks like, we know it's important to know that across time, right? One day is good, so you always have to start somewhere, but it's more important to know how is your progress over time. Is your blood pressure going up? Is your weight staying stable? Is your urine output going down? That could be a sign of trouble. And so you're going to want to be able to see those trends over time. And then you can share these results with your care team. And then lastly, we talked about, so now there's all those things to kind of keep track of, but there's also, you want information. You want to really understand. And we know that the more a patient understands, the better they do in taking care of themselves. And so this this area is really allowed to be something for everybody, right? So no matter, again, where you are in your transplant journey, giving you information about current transplant news, new developments in transplant, a lot of the things that Dr. Jordan was talking about this morning, as well as upcoming events and webinars like this one, even if they're virtually. That does help you kind of stay connected with other people, especially in this COVID time, and help keep you up to date. General news and information, again, about transplant, like, did you know that drones have started actually transporting kidneys? And then general education information. So things like articles on rejection and what rejection is, links to the FDA recall sites, links to medication assistance programs. So hopefully a little bit of something for everyone, again, no matter where you are in your journey. We have a video to kind of help highlight some of these and show you kind of the app in action, if you will. So I'm going to have us go over to that.
Suzette, are you muted?
I did. Could you not see it?
We could see it, we just couldn't hear it. Were you?
Okay. Okay, here we go.
Thank you. And now I think we were going to go over to Alex and have her share a little bit of her story.
Good morning, everyone.
Good morning.
My name is Alexandra Harrison Flaxman, and I am a two-time kidney transplant recipient. And to kind of echo what Lori said earlier and what everyone is saying in the chat, I would also not be here had it not been for Dr. Jordan and all his amazing therapies. My second transplant was very difficult. I was highly sensitized. I also did IVIG, rituximab, everything they could throw at me to try and just get me ready for transplant. And fortunately, everything worked. And now here I am about 7.5 years out, which is so exciting and so crazy to believe. I've struggled with kidney disease my entire life since birth. Since before birth, my parents knew that I was going to have these issues. And, you know, growing up, I've always been very involved in my healthcare, especially now that I'm an adult. And as Corin said, it's a whole new language. It's a whole new world when you go from whether just being on dialysis to getting a transplant, or go from, you know, being one of the lucky ones and getting a preemptive transplant without getting on dialysis. It's still a very different world, a great world, an awesome new life, but it's still completely different from being pre-transplant. And for me, it was really hard to grasp all the information, keep everything in one place, keep up with the, you know, weekly, daily, monthly medicine changes, what I was monitoring, what I didn't need to monitor anymore. So with the new app with Allocare, I love that it really is just a one-stop shop. I was very fortunate enough to be part of the early development and the beta testing, and getting to share, my input and my suggestions, and to see it come alive in, one place on your phone. I mean, these days we always have our phone on us 24/7, for better or worse. And to just know that everything I need is there. And then on top of that, because, I am 7.5 years out, I'm not monitoring the same things I was when I was, 3 months out, 6 months out. I'm not watching measuring my liquids as much. I just know what's right, and urine output. But medications, like, that's our lifeline, right? Like, we always have to stay on top of our meds. And sometimes if you're, out and about, or you're on vacation, or you're doing something, you just need that extra reminder, like, hey, it's time to take your meds. And, for me and my family, because they are very involved in my healthcare still to this day, it's nice that I have something on my phone where I can, show my husband, like, this is the list of my meds that I take now, this is the dose, and he has a place that he can go and look at it if someone had a question and for whatever reason I was unable to answer. I love that it's, again, customizable. I can easily turn things off that I don't need, turn things on that I do, day by day. It's not, it's not like you can't just turn it on today and then change your mind tomorrow. And because there is so many things that we're keeping track of when you go to see your doctor, I used to be one of those patients that wrote everything down and kept a notebook and went in and was like, here's everything I've written down in the last 3 months. And now I can, just show the app and say, this is what my blood pressure's been. This is how my weight's been fluctuating. And it's just been really nice to not have to rely on only myself, because, human error, to take care of the gift of life. This is my 3rd chance at life, and I hope to God that it lasts as long as possible. And really thankful to just have one place where I can go and manage everything. And it's very easy to use. It was very easy to adapt to. The articles are really interesting. It's nice to have all of my kidney related or health related events and articles in one place. And I just am very lucky to have gotten to assist in all of that. And thank you, Lori, for having me here today to talk and share my experience. And
I have a couple of questions. So when you take your blood pressure, do you just enter it in the app? Is that how it works?
yes, so
Take your weight, you enter it.
Yeah, so
does it know if you're lying with the weight?
I unfortunately do not have all of the awesome Bluetooth technology that is out there these days. So I do enter it myself. And in my mind, my mindset is that if you're downloading this app and using it in the first place, you're not going to lie. Like, if you're a compliant, educated, want to take care of yourself patient, you're not going to lie, right?
I'm just kidding. I mean, I'm like,
yeah, no, but that is an issue. And then, but as Corin mentioned, there's Bluetooth water bottles, there's Bluetooth scales, there's Bluetooth, I'm not a diabetic, so I don't know what the technical term is for this, but, to monitor your blood sugar, there's Bluetooth blood pressure cuffs, there's Bluetooth everything these days. And it's very easy to set it up to talk with the app and integrate.
I also have a question. So if you use the app, we all are on apps with our doctor's portals, and every hospital has a portal. Does it interact with that?
Do you want to answer it, Corin?
Sure. So Lori, great question. It does actually. So the way it interacts with your patient portal is you can link your patient portal to your health app in your iPhone. And then our app does talk to your health app in your iPhone, right? So it will then automatically track your steps and things like that from your health app, but it will also bring in your medical record information. So that's how it's going to bring in your medication list. we are working to develop a way to bring in lab results from your patient portal and show them to you in your app. That's a feature that will be released early in 2021. We have a way coming out later this month, so in just about 2 weeks, where you'll be able to download a report of all of the information you've been tracking and be able to send it to your provider either through email or you can email it to yourself and then put it in the portal and send it to your team that way. So lots of opportunity to be able to interact with that patient portal and be able to communicate with the transplant team from the app. Now, I do want to be really clear, there isn't a way to message your coordinator in the app. There isn't a way to, you can call your transplant center from the app, but it doesn't let you message. And that was really because we just don't want messages to get lost, right? We want your important messages need to get to your coordinators, and they all have different ways of communicating with their patients. So we just don't want that to get lost.
Thank you. One follow-up question too is, how is privacy protected, or what is done with the data that is used on the Alisher app?
So that's a really important question, Lori, and thanks for asking it. So we take privacy very, very seriously. And so the information is stored, it's HIPAA compliant and privacy protected. We have actually run, before we released the app, we did a lot of testing to make sure that it wasn't something that could be hacked into, or we put it through all of the tests that apps should go through to make sure that your data is protected. We are storing the data in the back end so that if you lose your phone or if you change phones, want to set it up on a different device, you can retrieve that data so you don't lose all the data that you've entered. But we are only going to use the data to help improve the app. So it will show us kind of what areas that the patient that you're using and what you're not using, and what folks are finding helpful and that sort of thing. So we will certainly use it to keep making that app better. But the data will be protected. We won't be selling that data to anyone. We're not giving that data to anybody. That's your data. And if at any time you want a copy of that data or you want us to remove that data, you can just request that and we will do that.
Okay, great. And then one other question as opposed to where is the app? Is it for iOS, for Android? What different options are available?
I see a lot of questions about that in the chat. So right now, it is available only on Apple. And I promise folks that is not my way of saying that Apple is better. I am completely agnostic as to devices. It's really because the Apple Health Kit is very easy from a development standpoint to work with. So we started with that. But we will be releasing an Android version. It will be available, it's planned for early 2021. Rana did include in the chat, if you let us know that you're interested, we'll make sure that you are notified when that Android version is available. Later this year, we will also have a Spanish version available as well. So those are two questions that generally come up.
Well, great, thank you. Any other questions that I missed? Well, I want to thank everybody for attending this webinar, very informative of how to protect our gift of life. And you can go to caredx.com if you want to learn any more information. We're going to be sending a follow-up email. Please make sure we have your right mailing address, and we'll send you a little goodie for attending this webinar. And we really appreciate you, taking your Saturday to come and be educated, because knowledge is power. And the more you know, the more you can protect your health and protect your well-being. So thank you for attending. And we'll end this thing, everybody. Have a wonderful weekend.